So, hey everyone, my name is Priyesh. I'm currently a final year medical student at UCL, and I'm also the marketing lead for QuesMed. And I'm also going to be starting an AFP post at St. George's in London this coming August. And as you can tell today, I'm going to be talking to you about QuesMed. So QuesMed is a question bank which really sets itself from the rest for a few reasons. I think one of the main ones is the fact that the questions make you think a bit more and more laterally. And on the next slide now, you can see a few testimonials about our question bank, but to just give you a personal one, as someone who's recently passed finals, I think I attribute a lot of that to QuesMed because I feel like the questions on there were the most similar to my finals. And also as someone who's going to be starting an AFP, I've used QuesMed for the past few years, and I attribute a lot of that to me getting a competitive decile to then attain that. Some of the main features that sets itself apart is there is a searchable, there's a global search function which allows you to search for topics. So say, for example, you're revising multiple sclerosis, you can search for that and then do either the Ques cards on that or the QuesMed questions. And so with the cards, there's over 15,000 Anki style flashcards, and these are all pre-made, so you don't have to make them yourself. And the sort of AI within QuesMed will automatically repopulate which cards you need to go over based on the questions that you get wrong. There's also a timed question mode, which is essentially there to simulate the increasingly common sort of online tests. So you choose a selection of questions, it will give you a time limit, and you won't see which questions you've got right or wrong until you've completed all the questions. And what's also really useful is that all of the features that I've mentioned, you can also access through the QuesMed mobile app, available on iOS and Android. And it also works offline, which, for example, for me, I used it quite a bit while I was on the tube, and also just within hospitals where sort of NHS Wi-Fi leaves a lot to be desired, you can still use the app. And today we're sponsoring the series of lectures, and you can use the code NSTS25 for 25% off in your questions. And I'll also be in the chat for a bit if anyone has any questions. But yeah, really recommend QuesMed, and thank you again for having me.
Lovely, thank you so much. So now I'm going to hand you over to a lovely F2 called Kat, who's going to be taking this lecture today. She's very experienced in lecturing and is at Liverpool currently. I'm just going to be giving you some really practical tips just about using a bleep, what a bleep is for, how you use it, and just all the things associated with that. So just over to you, Kat.
Thanks very much. I'll just share my screen now. Thanks, Lois, for the introduction. So today we're sort of doing an introductory session, mainly about doing your first surgical on call and answering a bleep. Most of this will be sort of things I hope you will have learned at medical school, but often lots of these things are sort of the softer skills that aren't necessarily medical content that are really important to know when you start as an F1. So I'll try and give you some hints and tips from my time doing surgical on calls as a junior doctor to help you through. So just a bit of background about myself, I'm an F2 doctor based in Liverpool. I did my preclinical medical school at Cambridge and then my clinical at Oxford, and then I've been doing my foundation programme up in Liverpool. And I'm currently on GP, but I've done some SHO surgical jobs. So I did TNO, and then I've also done general peds at Old Hay. And then I'm going on to do paediatric surgery next year as an F3 job. So I'm quite passionate about surgical teaching. So to get on and cover what we need to cover today. So these are sort of our learning objectives. So thinking about how to cope with your first surgical on-call shift, a bleep, what it is, how you get one, when you answer it, how you obtain important information, using sort of some frameworks to help guide you, when you need to bleep other people, and then how to prioritise your jobs. That's quite an essential role because in some jobs you'll be overwhelmed with tasks that you need to get on and do, and you need to be able to quickly assess which ones are important and critical to do right away and which ones can wait. And then we'll cover a little bit about giving clinical handovers. This is definitely something I don't think is particularly well covered at medical school, and you develop it really with practice, but just giving you a framework to use to know how to do a handover correctly. So to start off with, what is a bleep for, and how do you get one? So a bleep is primarily for sick patients and for urgent tasks. Everyone should hopefully know what a bleep is. They're big plastic, very unbreakable things that you wear on your uniform somewhere that make quite a high-pitched sound and go off, and they give you an extension number normally which you need to call. Very basic things in terms of how to use them. Every hospital has different numbers to call to bleep someone on the hospital main system. So for some it will be like a number 9, and then you insert the extension number you wish to, or the bleep number you wish to bleep, and then you put your extension number of the phone you're using. Different hospitals have slightly different systems and different numbers to call. So once you get to your foundation job, you'll get told how to do that. And then in terms of answering it, a really critical thing to do is to make sure that you record the extension number that comes through on the bleep. If you're really busy, particularly when you get into your F2 jobs, but possibly also if you're in a busy DGH where you're getting lots and lots of bleeps and you're responsible for lots of different wards, you can get bleeped several times quite quickly. So keeping track of the numbers that have called you and the time they called you so you can get back to them in good time is really helpful. And there's certain buttons that you can use, but no one really knows how any of them work, and different bleeps have different ways of deleting the number and things like that. And then you essentially just call the extension number on the phone. So that just covers the very basics of it. So getting back to what the bleep should be used for, or what other staff should use your bleep for. So the most important thing is seeing sick patients, and these are patients that you need to go and assess in person. And then urgent tasks. So this can be a huge range of things. Many of them can actually be dealt with virtually if you're lucky enough to have an electronic system at the hospital you're working at, but I know that's not always the case everywhere. So these are things like prescribing, communicating, so someone might ring you from the lab or from radiology to communicate that a scan result or a laboratory test is available for you to look at and for you to perform management as a result of. Or it could be a clinician calling you that wants to discuss the management of a certain patient. And then also you can get bleeped by various staff to do other tasks such as bloods and cannulas, death certification, and then non-urgent review tasks, or communicating with the family of a patient. In some hospitals, you're lucky enough that on call, your bleeps might well be filtered by other healthcare professionals, particularly nurse practitioners, who can be phenomenally helpful. Or there may well be an electronic system onto which on-call tasks are placed, and then you're able to sort of triage them yourself. But in many places, particularly in DGHs, your bleep will just be used for anything and everything. So imagining that you are on call and you've just been bleeped, it's your first day as an F1 and you're unfortunately on a long day. So it's in the evening, you've had your handover and you've been bleeped by a nurse about a patient. What are you going to do? So we're now going to discuss an approach or a framework that you can use and that will be used continuing throughout the series of lectures that are being given to go through different scenarios. So sort of first thing to think is to just stop and remain calm, particularly at the start when you get bleeped. It can be quite stressful. And again, as I said, if you get bleeped lots and lots of times, that can be really stressful. So you need to establish some really key information, the most important information being who's bleeping you, and also so that they know who you are to make sure they've bleeped the appropriate person. So what is your role and responsibility for the patient that they're bleeping you about, or the problem they're bleeping you about? And then making sure you know who they're bleeping you about. So making sure you get the patient's name, ideally a hospital ID or their date of birth, so that you can either find them on the electronic system or find their notes appropriately when you need to. And then also where they are geographically. So what ward are they on? What bed are they in? Or are they in a clinic or elsewhere? And then what the problem is. So the key thing in terms of assessing what the problem is to think about how urgent is this problem. Your main job that I would say to think of when you're an F1 and you're on call is to keep the patients alive until the day team are coming, whatever that might be, whether that's in the evenings, whether that's overnight or whether that's at the weekend, your job is to make sure that critically unwell patients are stabilised and are kept well so that the team that knows them best can manage them. So you need to know how urgent things are so you can manage them and assess them appropriately and see the things that are most urgent first. And then other things to do is, depending on how you know, the healthcare member of staff that's calling you and their level of expertise, what more information can you get about them, about the problem, and are they able to tell you other things such as the patient's observations, their AVPU, and also critically the speed of deterioration of the patient. This is all assuming that they're calling you about a sick patient, by the way. So then thinking about, while you're still on the phone, formulating a plan once you've gathered some information, and sort of having some initial thoughts about the problem. So can you sort this out over the phone, or do you need to come and see the patient? And then can you get anything done before you arrive? So this is something that's an adjustment to come from medical school into foundation being a doctor. Often at the start, particularly I found this, is that you feel that you need to do everything yourself and that you need to get on and, you know, you want to be doing everything, but the nurses and other healthcare staff are absolutely fantastic and they can help you, they can do tasks. Often actually they can do things a lot more quicker than you can and actually often are much more experienced at doing them. So can they do repeat observations for you? Can they get access? Lots of them are amazing at doing access if you just ask them. Can they take some initial bloods for you? Can they do a blood glucose? Can they put a catheter in so that you've got a urine input and output? Can they get the sort of things ready for you? So an OBS chart, an ECG, they can do a urine dip, and then also just gathering other equipment. So silly things like a tendon hand, which are impossible to find, or things that you might need urgently that you're not going to know where they are because often you'll be covering wards that you don't necessarily work on during the day. And then also thinking about, if this isn't a critically unwell patient, is this something you can sort over the phone? So is this something that you can provide reassurance for? Is this a really small thing that doesn't need seeing now? So is this a patient maybe that's had a rash for 3 weeks and the nurse just wants you to review it? Can you sort of find out more about what's actually going on there? And is this something that you need to go to right away, or can it wait actually for a day or so? Is it a virtual task that you can just do sat at a computer? Or also managing your workload, is this something that you can delegate? And can you manage the person that's ringing to you's expectations about how likely it is that you'll be able to come and see them urgently, or how long it's going to take you to get there, for their own reassurance, particularly if it's someone critically sick? They need to know whether you're on your way or whether they can call someone else. Or are you absolutely run down with other things to be doing and this person's not actually that sick? So making that person aware of how many other things you have to do will give them an idea, a realistic idea of when you'll be able to arrive. So you've done this, you've hung up the phone and you've written this down. So what are you going to do when you're on your way to the ward? Because in this scenario, this is actually a patient that you think needs to be assessed because they seem like they're deteriorating. So these are just some things to sort of think about on your way. It doesn't cover everything, but just particularly when you're on a surgical on-call, stuff to be thinking about as you're walking down, or maybe you've had a quick look at their electronic notes before you've set off for the ward. So we're on surgery. So what surgery has this patient had and when? Critically, when did they have it? So we can think about post-op complications and the most likely thing that could be going on if someone's deteriorating. What's their background history and what is their normal function like? So particularly for surgical patients, they can become quite delirious and they can become very unwell. And it's really useful to know or to think about, how well were they before they came to hospital or before their operation? And is this new? What drugs are they on? Do they have any allergies? And critically, are they on any antibiotics? So are they already being actively treated for an infection, or is that something that you need to think about? Thinking about, you need to prioritise giving them pain relief if they're in pain. And then how serious is this? So in terms of that, we're thinking when we arrive, are we going to be taking a history right away, or are we going to go straight in and do an A to E, or are we going to just literally check on them and immediately call for senior support? So then you've arrived at the ward, and you get to the ward. So this is sort of a structure of sort of seeing someone on the ward, which I didn't do at first, but then quickly took on and learned from either myself or colleagues' mistakes with going to see someone in person that might be deteriorating. So to me, always the first thing I do when I step foot on the ward is walk past that patient's room or their bay and eyeball them to check they're not critically unwell, because sometimes in the time it's taken you to get to the ward, they may have become much more unwell, or you may have been really worried and rushed there and they're actually fine. So that can help you decide how long you take to sort out the other things before going to assess them yourself. So a really helpful thing is to get a handover from the person that called you on or that you spoke to on the phone. This is often a lot easier said than done, particularly because the nurses have loads of tasks they're doing. They might be busy preparing drugs in the utility room. They might have gone on their break. They might be tending to another patient. But ideally, speaking with the person that you spoke to can be really, really helpful to just find out a bit more information and just, get a feel for what's going on and what they're concerned about. And then gathering your notes and having the up-to-date observations. So ideally, if it was someone who was deteriorating, the nursing staff may have done another set of observations, so you'll know if things have changed. And then having your equipment together. I tend to take equipment I think I might need with me. So if this patient doesn't have any access and I think they might be unwell, then I'm going to be taking my bloods and cannula equipment with me so I can do that at the same time to save myself time. And then in terms of also having the notes is logging into a computer if you can, just so it's nearby so you can check things or you can quickly record your notes. And then going in to see the patient, obviously introducing yourself and your role as you would when you see anyone. And then because this is a sick patient, you want to be taking quite a brief history and then doing an A2E assessment. So in terms of your assessment, as I said, brief history is the priority here. You can get a lot from speaking to a patient and also from just looking at them from the end of the bed. But this isn't a medical school OSCE history here. This is how sick is this person and what can I do to help them right now? So the most important thing is really when we're speaking to them and we're finding out what sort of cognition level they have, how alert they are they in any pain and where is the pain, and just covering that briefly. You can do Socrates if you like. And then getting their experience of their symptoms and how quickly things have changed from them. Then obviously from the notes themselves, you'll be able to get relevant information about the patient's background. You'll be able to see the trends in their different results and also in their observations and also any other investigations that are important for you to know about. And then, as I said before about getting a handover from the person you spoke to on the phone, a collateral history, actually in any form, can be super helpful. So sort of hopefully post-COVID times, potentially there might be a relative at the bed. So plenty of times when I've done surgical on-calls, there's been a relative with the patient who's sort of said that they're not their normal self. And that can be really helpful to understand whether they're sick and what you need to do. Also, healthcare assistants are amazingly helpful for this too, because they often see the patient a lot more than the nursing staff or the doctors do. And then just having a look at their medications that they're on and their allergies. And then doing an examination. So doing an A2E examination. So hopefully you're all familiar with that. And then either having a new set of observation or actually taking the observations yourself to establish what their new score is and how that's changed. So then once we've done our assessment, we want to be thinking about differentials. So what are you thinking is going on is the critical thing to be thinking, but then also at your stage, you want to be thinking, can I manage this myself? Is this something that I can treat and investigate and sort out and the patient will get much better? Or is this something I need to immediately speak to a senior about? Or is this something that I can manage first, do some initial steps, and then potentially contact a senior with a bit more information? The critical thing to say is that do not feel afraid to ask for support. Don't wing it and manage a difficult situation yourself. Often that ends much more badly than calling someone when you think it might be too early. So I've been told quite a few times that the safest doctors are the ones who call to what they think is someone who actually isn't very unwell, but calling early is really really important, and no senior should be upset about being called about a patient that actually turns out to be fine, because your job is to make sure that the patient's safe. So then just having a think about investigations based on your differentials, and just the principles of doing them. So you need to think about basic bedside things. So as we said, things that perhaps the nursing staff may have been able to do for you on your way, things like a blood glucose, getting a pre and post void bladder scan, or getting a catheter inserted and seeing what the residual volume is, getting some bloods and sending them off to the lab as a priority, and then just thinking about imaging. So thinking from basic up to more intense imaging, and also potentially whether you need to discuss that with a senior or if you're able to call directly. So in lots of hospitals, things like CT scans are only able to be ordered by registrars or above. That's a new sort of safety mechanism that's been introduced, which can be a bit of a nightmare because often you know the patient best and you actually are the best person to discuss a scan with a radiologist. But just knowing the protocols that exist in your hospital so that you can make sure that you alert the right person to be able to get the scan you think you might need. But also thinking about radiation exposure and what other imaging has the patient had recently. So do we need to repeat it? Or if things have changed, then do we need to repeat it? Almost certainly. But if things are similar to before, then perhaps we don't. And with all these things, you can ask for help. So don't think, as I said before, that you need to do all of these things yourself. You can potentially ask another colleague who's on call with you to help you out if the patient's really unwell. You can ask a senior, you can ask the nursing staff. You can discuss it with lots of different members of staff so that you can work out exactly what you need to be doing. And then obviously you need to think about your management plan. So you've done some investigations. What are you going to do? So something that can be quite common at first is to just think, right, we'll do the things that almost everyone gets. So ECG, some bloods, a chest X-ray, and then get them reviewed by a senior. Unfortunately, that's something that we want to move away from, because if you've been thinking about what the differentials are, you might have some ideas about what's going on, and just doing broad brush things can be really helpful, and it is a safe thing to do if you're not sure what's going on, but isn't really a plan. Sort of thinking of things as a learning opportunity and practicing different management plans, and also having, recently passed finals and having the confidence behind you that you know medicine and that you can make reasonable plans even at your stage is what we need to be thinking, really. And then senior review, actually that is critical and that is an adequate plan, but you need to make sure that you do actually inform your senior. So ideally you should be bleeping them yourself and having a discussion over the phone, or getting them to come and see the patient in person, and you can be there to give a handover. And then you can learn from their plans. So you make your own plan to start with. It may be that you're not sure what to do, but just make a plan in your head, even discuss it with your senior, see what they do, and compare and contrast what you thought and what they've decided to do. And actually you will find with time that the plans that you've made are almost identical to what your seniors would have done. So that can be a learning process. So then in terms of documentation, so this is quite a critical thing, and regardless of whether this is electronic or on paper, there's some really important things that you make sure you write down. So critically, the time that you've gone to do your review, and also your name and your role. And a lot of people, especially in written notes where there's not as much of an easy audit trail, like to put their GMC number down as well. And then a good structure to sort of follow is you've been asked to see a patient regarding, and then whatever the reason for your initial bleep, you can write down. So it might have been chest pain, might have been shortness of breath. Write down what that initial reason for you to be called was. And then if you have time and you're not run off your feet with other patients you need to go and see, and you want to have a good think about this, you can write a brief history of the patient and the reason that they'd come in, and potentially, day 2 post-op laparotomy or whatever in the notes there. But previous notes will have been quite thorough in recalling that, so that's not critical to write down. Thinking about sort of the clinical details of what happened. So how was the patient before, how have they changed, and then your A to E assessment. So literally just writing A to E and putting your findings for each thing is absolutely fine. And then the investigations that you did, and if there's any results back, popping them in there, or writing down things you're awaiting. And then some people like to write a differential diagnosis, but I actually prefer to put an impression, but that's sort of your own sort of choice, but putting an impression of things that are going on, particularly if you're not sure exactly of a diagnosis, but you can put down some potential current differentials in the notes if you're happy to. And then having a management plan that's good, that's logical and that's safe, that's based on the impression that you've made before. And then any further action you're going to take or any referrals you've made and discussions with a senior. And then leave your bleep number in that note as well so that the ward can contact you again more easily, because oftentimes they'll have had to have ring switchboard to get your bleep, or they'll have had to have looked at some crumpled piece of paper that someone's handed them to find out which doctor's on call, because it may be that you keep your bleep with you for the whole rotation, or it may be that it's a baton bleep that's carried around. So then thinking about other structures for note taking. So that's just one that I have followed, and this is quite a similar one actually, but this is also really useful for surgical ward rounds, which particularly you will find if you are doing written notes, they're super fast moving, and it can be really difficult to keep track of the note taking, but also to bear in mind what you need to know about that patient. So sometimes you can go on a whole surgical ward round of a whole ward and find that there's some patients where you're not even sure what the plan was or what you needed to do that day. So putting the situation, so date, time, who was present and who was leading the ward round, a brief thing about the patient's background, and then their working diagnosis, what operation they had and how many days they are post-op or if they're pre-op. And then the subjective things, so how do they feel they are they in any pain? And then objectively, so things that you've noticed on sort of looking at the patient, so comfortable, sat up, in chair, things like that. And then recording the assessment, so putting their news or observation score in the notes at the time, or the most recent observations that were done, and then recording the examination. Don't be afraid to ask the senior doctor that's performing the ward round on ward rounds to shout out what their findings are. Sometimes there can be a lot of people on a surgical ward round, as you probably found in your experiences. And actually knowing what the findings are can be quite tricky, particularly if it's something like abdominal tenderness. You might not have caught where the tenderness was, or if there's any positive signs, you know, that might be things that you've missed, and that can also be a learning opportunity, even though the priority for you at that time is to be recording the notes. And then thinking about the plan, so ideally you should be sort of formulating this on the ward round too, but often these things will be dictated to you by a senior. But don't be afraid to ask for more details. You know, surgeons can have a tendency to rapidly move on to the next patient because their priority often is getting to theatre or clinic. But bear in mind that the patients are your responsibility once they leave the ward. So you need to know for your own clarity what is going to be done. What's the priority for that patient today? So is that fluids? They need more bloods doing? Do they need change in their medications or their antibiotics reviewed? Do you need to bring microbiology to discuss their antibiotics? Should the patient be nil by mouth? That particularly is something that the nursing staff will often come to you to ask. So helpful to ask if you're unsure on the ward round. And then the two critical things which trip people up the most in F1 when they're on a surgical job is imaging. So often a senior doctor might say, get a CT scan, but there are all sorts of different types of CTs with different forms of contrast, with no contrast, of different areas of the body looking for specific things with specific phasing. So it's really invaluable that you ask what imaging is needed and why. Don't be afraid to ask this, particularly also because, again, as I mentioned before, when you're on call, again, during a normal day job, when you're ordering scans and investigations, often you may well have to have a discussion with a consultant radiologist about the scan and why you need it, and particularly on surgery when the scans tend to be quite particular for surgical planning and such. Knowing why it needs to happen is really helpful, because otherwise you'll have a conversation with a consultant and then you'll have to go and find your senior to find out what the reason was, and it just, you know, it would save you time to have known at the beginning what you needed to find out and why. And also so you can put it in the request. And then also discharge plans, so prompting a senior or the consultant about these is really, really helpful. Remembering that as an F1, you don't have the authority to independently discharge patients. So for that reason, you do need to know what enables them to go home later days. They might say fit for discharge, but there might be a condition on that, such as they've passed urine. So you need to know those things. And then just to cover a little bit about how to escalate to a senior, because I've mentioned a lot that, you know, contacting your senior is really important. So as I said before, just to reinforce, if you're worried about someone or you're not sure what's going on, then it's never too early to ask for help. No doctor should ever criticize you for asking them for support. As an F1, you're still in a role where you're learning, so you're there to be, you know, to get supported where you need to be. If it's an urgent situation but the patient's sort of relatively stable, you need to have a discussion with someone more senior because you think more things need to be done. Then the first port of call is normally to speak to the surgical SHO or the registrar on call, depending on how your hospital structure works. Oftentimes, especially out of hours, they can be in the theatre or just unavailable. Sometimes also, if you're in a particular specialty and you need to call that specialty's registrar, say the patient's had a fracture and they've got some pain post-op, or someone's fallen and perhaps broken their hip and you want a orthopedic registrar, sometimes they can do resident on-calls where they're based in an on-call room and they have a mobile, but oftentimes that mobile might be switched off if there's rota gaps and things. So sometimes you won't be able to get hold of the person you need. If you've tried those routes beforehand, or you've tried other ways of getting through, whether through switchboard and things, and at that point you can ask the medical registrar on call for help. And also for post-op complications that tend to be medical things such as pneumonias, asking for support from the medical reg on call can be really helpful. And especially in those first few weeks where you're unsure, that's absolutely fine, and they should be welcoming of that. The other people is, depending on the hospital again that you work in, lots of hospitals now have a critical care outreach team. So this is for patients that are deteriorating on the ward who could possibly be needing HDU or ITU. And these are often really experienced nurse practitioners or even junior doctors that can give you a lot of support, can help you get access if it's really difficult, can assess, and they often have a direct line through to an ITU or HDU consultant, so can get the patient admitted quite quickly if you're unable to get hold of your other seniors sort of on the ward level. And then if things are less urgent or you're not really sure who to ask, then again, the SHO is a good port of call. Or sometimes if you're on call, there might well be an F2 working with you on the team. They will have probably a lot of experience of going through the sort of common things on call, because there tends to be patterns of conditions that you'll see, and they'll have got to grips with that, so they're a really useful person to ask. And then also, if your hospital has them nurse practitioners, they're really useful, and can also, sometimes you might just need an extra pair of hands. So often you'll find that in the first couple of weeks or month as an F1, things can be quite scary and overwhelming, but then you'll start to get to grips with what you need to be doing. But sometimes when a patient's quite sick, it may be that you just need more help. So you want to be ordering a chest x-ray, you want to be doing their bloods, you want to be doing an ABG, and just having another pair of hands or a couple more pairs of hands can make things a lot quicker. And then on that note as well, if it's getting to a point where you feel that this is a peri-arrest situation, then obviously putting the buzzer, calling for help, and asking someone to put out a 222 call. You need to specify at lots of hospitals, so I'd say in general just at all hospitals, when that person makes that call, if it's a cardiac arrest or a situation where the airway's in danger, then make sure you specifically ask for an anaesthetist, because not always do they come. And then some hospitals have a really brilliant new system, which is a medical and emergency team, or a MET call as it's called, and often that's by the same method, so a 2222, and that tends to bring a junior doctor like an F1 or F2 that's on that bleep for the day, an SHO, the medical registrar, and then it might well bring the critical care outreach team or nurse practitioners who work on that team, and they can sort of assist you with looking after someone. And in some hospitals, if a patient's news score reaches a certain level, then they're the sort of the protocol that the nurses have to follow is just to put that call out. So you now sort of have some idea of how to handle a bleep and sort of the things to do. And then I've covered a little bit about some tips and tricks for surgical ward rounds and also just for escalating to a senior. So I mentioned before about you might well get a lot of bleeps in one go. So what are you going to do when that happens? So as I mentioned before, keeping accurate records is really important and good practice. And for myself, I didn't find so much as an F1 I needed to do this because I was fortunate enough to work in a hospital where our bleeps were sort of filtered by a nurse practitioner, and most of the urgent tasks we needed to do were on an online system. But when I was working as an F2 on trauma and orthopedics in a major trauma centre, I was getting up to 10 bleeps in the space of 2 minutes. And if I hadn't have been writing down the bleeps and the times, I would have completely lost track of who would bleep me and being able to get back to them in a timely fashion. So having a piece of paper when you start an on-call shift, blank piece of paper, scrap paper, wherever, and starting and having the details, the time that you were bleeped, what the bleep number was, what the situation is and the task, and putting the patient ID down. And then you can make sort of like a jobs list for yourself of tasks you need to do relating to them. So once you've assessed them, you can just write down things and, you know, chase chest x-ray or check the bloods and things like that. So you just can keep track of all the patients that you've seen in that shift and make sure that you don't miss jobs later on that you need to go back to. And then we talked a little bit about how to sort of filter out and work out on the phone which bleeps are more important. This is something that comes with experience, but quite quickly you'll sort of realise things that are critical, and you'll know from your own learning in med school stuff that's important to go see ASAP. So just some examples here, someone that a nurse has called you about who's got low blood pressure, who is febrile, versus what can actually sound to the nurse to be quite urgent, which would be completing a discharge summary. So a critical thing to remember is that, as I said before, when you're on call, your priority is to keep the patient safe and alive until the day team, who are most experienced at looking after these patients, are there. So in that sense, doing a discharge summary is not a critical task for you. It might be a very helpful task to be done, and it might save a lot of anguish for a patient. So I'm not saying it's not an important task to do. But in that scenario where you've had 2 bleeps, going to see the patient that's got low blood pressure that's febrile is much more important. And then again, patients who's having chest pain versus a medication to take home that needs to be signed or done, you need to go and see the patient that's sick. Always go and see the patient that's sick and manage expectations of who you've been bleeped by, and explain that you've got a number of more urgent tasks. And also there may be people that can help you with this. As I said, at the hospital I worked in F1, there was nurse practitioners that filtered bleeps, but also were able to help with on-call tasks. So often a discharge summary can be quickly completed by someone with enough clinical experience to read the notes and see what's happened. But actually you have the skills to go and see a sick patient and assess them, which is what your priority is to do. And if you do feel overwhelmed with the number of tasks you've got to do, then just take a moment and just have a look at your jobs list, and you can even just number them and prioritize which things you want to see. If it's getting to the point where you feel like you've got too much to do and there's too many patients that need to be seen right away, then contact a senior. And the other people to help is ask your colleagues. The other foundation doctors that you work with and meet on your rotations will become your friends. They'll support you. In certain hospitals, especially bigger hospitals, if you're doing a surgical on-call, there'll often be 3 or 4 other F1 or F2 doctors that are also doing an on-call that evening. And you can work together as a team, help each other out, you know, make sure you've got the phone numbers of the people that you're working with, and have a plan to take a break at a certain time. And, you know, they may well be able to help you with things. Lots of my friends, and I'd help my friends with doing sort of tasks, quick tasks, like things like warfarin prescriptions that had been left, or checking someone's bloods and just filing them, so that when they were having a really, really busy on call with lots of sick patients, they didn't have to worry about those small things. And then something else I just wanted to mention is more sort of like human factors thing, and also sort of communication skills and managing your workload. Sometimes when you get a call from somebody or a bleep from somebody to go and see a patient, the impression you might get on the phone could be that the person's really sick, or if it's difficult to understand what the problem is, someone might just say to you, come and see this patient, and be reluctant to give further information. That doesn't necessarily mean it's a clinical priority. So it's really important that you clarify the reasons you've been asked to go and see someone, because it can be really easy to just think, oh, I'll just go to the ward and see them, when actually you've got a much sicker patient elsewhere. And then something else to mention in terms of your jobs is things that should be done by the day team when you're on call, that you shouldn't really be doing. So as I said before, sometimes warfarin prescriptions can be left. They're things that should be done by the day team. And also, if a patient's stable on the ward post-op, they're needing fluids and they're having their input output looked at, the fluids for a 24-hour period should have been prescribed by the day team. So if that becomes a consistent task that you're being asked to do on your on calls, that's something you should raise, because those aren't really things that you should be having to do while you're on call. Obviously, for the safety of the patient, you should do them. But if it gets to a point where that's becoming a repetitive thing, then it's stopping you from doing the other critical things you have to do, such as assessing the sick patient. So you should raise that. And just helping out your colleagues as well. And when you're working on a ward, making sure you don't do those things before you go home, so that your on-call colleague doesn't have to, because it's a lot quicker for a person who knows a patient's ins and outs and everything about them to do that than somebody who's never met them before. And it might require them to spend 5 or 10 minutes looking through all the notes, checking their U's and E's, and actually doing a clinical assessment of the patient before they feel comfortable to prescribe the fluids that you could have done in a minute. So then, sorry, this is quite a busy slide. I've written out 5 scenarios here of different bleeps that you have received. And I just want you to take a moment to think about the priority that you would go for in terms of addressing them, and then we'll talk through them. So just give you a couple of minutes now to just have a think. Oh, sorry. Just give you another minute to have a think. I'll say now, there's no particular right or wrong answer, but I'll just do a bit of explanation about each of them in a second. Okay, so just go through each of them in turn. So just more of a thinking exercise for you to sort of imagine yourself in this situation. And this is quite a common thing, and all of these scenarios of bleeps that I've had when I've been on calls, or similar type bleeps. So the first one, an IVD with vascular disease who went to the toilet, he's come back and he's really drowsy and his breathing slowed, and the nurses are really worried about him. So from the sounds of that, this is possibly someone that's shot up something, whether that be heroin or something else, that's made them reduced consciousness. So that's definitely a clinical priority that you go and see them. The nurses explicitly said she's very worried. Obviously, you'd need to gather more information. This is just a brief summary of what they've told you, but that's definitely something you should be going to see as soon as you can. Then the second one, the wife of a patient wants to speak to you because she's really distressed about him being a lot more confused and that he's seeing things, and he's had an operation 2 days ago, but since then he's been okay. He then got quite agitated on the ward earlier, but he's much more settled. So this is someone that sounds like they potentially have post-operative delirium. The nursing staff have been flagged to it by the wife. He's stable at the moment, but he's been very agitated, so potentially could get agitated again. So considering the safety of him and the other patients on the ward, but also if you're completely overwhelmed, and here we have got 5 things to go and see, he's currently settled. So this is possibly something that could wait a short time while you do see the other patients, but you need to go and do an assessment for delirium for this patient. And then we've got a person that's bleeped you about some daughters who are some family members who are really upset because they don't know what's wrong with their mum, and they're insisting on speaking to someone. And this can be very common in normal times. And as we go back to having visitors on the ward, unfortunately, when it's very busy in a very busy hospital environment, unfortunately, sometimes family members can get left out of discussions, or could have had things explained, but they've not fully taken them in. And once they've had time to reflect, which often will happen when they come to visit the patients in the evenings, in evening visit times, or the weekends when you're the on-call person. You know, she's been newly diagnosed with pancreatic cancer, and it seems like there is a plan in place, which the staff have helpfully told you that there is a plan. So we're assuming that you're maybe on call at the weekend. So this is a really difficult one and can be quite challenging to deal with, especially when you've got lots of other demands on your time. It is really important that you do go and speak with the family, but equally realizing that you don't know the patient and making them aware of that, but that you're able to interpret what's going on and what's happening in the management plan as best you can be really helpful to just ease anxieties and sort of help ensure that they're happy and that the patient's also happy with the care and understands what's going on. But equally, there's a plan, finding out if there is a plan. So in this case there was, but finding out if there is a plan for there to be some sort of meeting for discussion, especially with senior doctors there to talk about the implications of a diagnosis, can be really, really helpful to know, and can mean that you don't have to spend an hour or 2 hours of your shift speaking with a family when you don't actually really know what the plan is. And then number 4, so patients returned from theatre. He had a frame fixation of a tib-fib fracture. He's now complaining of a lot of pain. He's been given some pain relief and it's not made any difference. So here, sort of thinking about the immediate thing in your head should be, could this be compartment syndrome? It's the right type of patient and the right sort of presentation. So that's, again, something that you need to go and see as quickly as you can. And then the last one, an 81-year-old lady who's medically fit for discharge, but now she doesn't seem well and she's got a new score of 5. So again, sort of clarifying exactly where the observations have gone off. And this is a really, really common one. Don't be lulled into a false sense of security by the fact that a elderly person has sat on a ward for up to 3 weeks and been completely well, and all they've needed from the hospital is their meals, essentially, and their physiotherapy, awaiting maybe a nursing home bed. These patients can often suddenly deteriorate out of nowhere, and you need to go and do a thorough assessment of them and put a management plan in place. Often they'll have a hospital-acquired pneumonia or other infections such as a UTI. So again, that's someone you need to prioritise going to see. So then thinking about handovers. So you've made it to the end of your on-call, you've absolutely exhausted, and you're desperate to get home. So what information do you need to pass on to the next person who's taken on your role? So the critical stuff that you need to make sure you tell them about is the patients that are unwell that you've seen, patients to be aware of. So this could be somebody who's been handed over to you as a quite complex patient, so they needed a verbal handover to you, but they've actually been fine. But if something were to go on, you need to know what a management plan would be. So this might be somebody who's come back from a parathyroidectomy, for example, that potentially could have a hypocalcemia attack. So you need to know what the management plan would be. That could be something that might have been handed over to you. And then also anything outstanding. So often I find it's quite helpful to take the last 5 minutes of your shift, rather than trying to address any more issues you've got going on, to just look through your sheet of paper that you've written all your tasks on and just see if there's any tasks outstanding. And is there anything that you can quickly do, such as just check someone's blood results, or just review that chest x-ray to get a sort of full diagnosis, so you don't have to hand over things that are sort of undone. And then also investigations or bloods that need to be chased by person. So Again, this will need a handover of the patient and the clinical situation. But these sort of things are things like troponins, gentamicin levels or other antibiotic levels, and then INRs or clottings. So you kind of want to make sure that you're doing a effective handover that covers all the salient points, but also something that's safe, that's protecting patients, and also ensures that the relevant management plans that you've made during your hard working hours on call are enacted and continue to help the patient when you go home, especially also so you can wind down when you get home. So I'm just going to give you a bad handover and then give you a good handover just for an example of difference. So this is, I'm an F1 colleague handing over to another F1 colleague. So there's this patient on ward 5, or actually I think it's ward 10. So their name's Mr. Smith, and they've been in hospital a while and they had something done to their abdomen a few days ago. They're unwell again today. I'm not really sure what's going on, but I didn't have a chance to discuss it with anyone because I was really busy. So I'm just waiting for their bloods, their ECG and their chest X-ray. Could you review those for me? And also I haven't seen them since sort of a couple of hours ago. So actually, could you just do a clinical review? So just unpacking that in terms of the information you've received. You've not really received a great deal of information. You've not been told really who the patient is other than that their name's Mr. Smith. They're not sure of the location of the patient. You've not got any identity for them. You don't know how long they've been in hospital or their background, other than that they've had something done to their abdomen. And all you know is that they've been unwell and that they've had some investigations done, but you don't really know what the clinical impression of the doctor was. So these are things that you need to know and that you can challenge. So if someone hands something over to you and you're unsure, ask them questions until you feel you have a good grasp of what the situation is. So then a good handover is using the SBAR framework. So, you know, looking at the situation, the background, assessing them and thinking about what the response should be for the clinician you're handing over to. So I'll give you one of the same patient now, so then you might realise a bit more that's been going on. So this is Mr. Jack Smith. His hospital numbers RQ657891. He's on ward 10 in bed 4. And he's a 51-year-old gentleman who is day 5 post-op anterior section for colorectal cancer. And he's got a background of ischemic heart disease and type 2 diabetes, which he's on insulin for. This afternoon, he spiked temperature and he became tachycardic and hypotensive. His abdomen was soft and tender, but he had some crackles on auscultation at the right base. So I've started him on empirical antibiotics for a HAP. I've taken some blood cultures and I did the rest of sepsis 6 for him. He's also had an ECG because he had some chest pain. He's got some old QAs, but there's no new abnormalities. I then reassessed him and his blood pressure had come up with a fluid challenge and he's clinically improved. I managed to check his blood just now and his blood showed neutrophilia and a raised CRP from his post-op baseline. And I've called down for a mobile chest X-ray, so could you please check this? And if you could get a chance, could you assess his fluid balance later and just see if he needs any additional fluids? So that, as you can tell, is a much better handover in terms of covering this different things you need to know. So you know enough about the patient themselves, you know more about the background, you know what had happened and what the assessment of the doctor that saw them was and what management plans have been put in place. And most helpfully, the doctors managed to go back and just take stock and reassess the patient to see whether their management plans made any difference. And in the same way, they've still done an ECG, bloods and a chest X-ray, but they've managed to chase some of those investigations and have handed over appropriately something for you to do, which is to check the chest X-ray. And so it sounds like you have an idea of what the differential that they're working with is and what's wrong with the patient. So those are really important things to remember with unwell patients is what's the background, what happened and what did you do? What treatments are they now on? When do they need a reassessment? So does that need to be in the next hour? Does it need to be in the morning if it's a night shift so they can manage to sit for a couple of 10 hours, up to 10 hours without being seen? What's the escalation plan? This can be really critical, especially for surgical patients where there's a tendency for these discussions to not necessarily be had. So it's good to clarify these sorts of things because in a busy shift, you might not have the time to figure this stuff out. What is the escalation plan? If this patient is very sick and does get more sick and gets critically unwell, are they for ITU? Are they for CPR? Are they for any investigations or interventions at all, or are they to be kept comfortable if it reaches a certain point? So those are things you might want to know. and also asking your colleague who they've called for senior support or who you should call. They may well be able to tell you, oh, actually, I spoke to the vascular registrar and they're happy to be recontacted about this patient. And that information could be really helpful for you to know. And then also other things with your handover is to, if you can, update. Some places have surgical lists. If you get the chance, updating the list so the patient information is up to date. And as I said, and handing over every unwell patient individually so that the person taking over your role knows what's wrong with them and who they are. And then, as I said before, handovers are just really important because it allows you to leave work with a good mindset. On-calls can be really, really busy, and often you can get home and start to then reflect and process things that have gone on and worry. And having handed the things that you had left to do and the sick patients that you've seen over to someone can really put your mind at ease and help you relax when you get home. And then another point to say is we live in a modern age, and also remember that when you're in a group of F1s, there's always going to be someone at the hospital that's taken over from you. And in my cohort of F1s, you know, it would be one of us to the other for 24/7 for the whole of the last 2 years. Has always been one of, you know, people in the hospital and doing the job role that you've just done as an on-call. You'll have a WhatsApp group with everyone in, and especially in the first couple of weeks, if you're worrying and struggling or worrying about, say, someone's potassium on a blood test and you can't remember if you checked it, you can message them and ask them to check for you. I would discourage you from doing that sort of later on, and you'll probably find anyway that as you've done some on-calls in the first couple of weeks and months of being an F1, that these things don't bother you as much and you are able to sort of reach a good equilibrium of concern but also relaxing when you get home. But if you are worried, you can always contact someone. And actually one time I even called the ward of the hospital and just spoke to one of the nursing staff and just checked something so that I could just put my mind at ease and go to sleep. So that brings us to the end of the first session. So I hope that's been really helpful to you. I realise it's been quite general, and I've not really covered many specific scenarios, but the following lectures are going to cover sort of specific scenarios you might face on a surgical on-call in more detail. So thanks very much for listening. And please do follow the QR code so that you can just give us some feedback. Thanks very much.
Lovely, thank you so much, Kat. That was great. Really useful things covered. As Kat's just mentioned, if you're looking for some more specific cases, we have things on prescribing, things like fluids, abdominal pain, all of that is going to be covered over the next 4 weeks. We've got 2 lectures per week, Tuesdays and Thursdays. So if you'd like to hear more, then please tune in and join in for more things. In terms of questions, there's a few questions. If you'd like to hang around for these, please feel free. There's also, yes, a QR code for the survey. You can fill that in for Kat just giving up her time tonight to speak to us, and that'd be really appreciated, so thank you. So some of the questions so far, how would you approach confidentiality with the pancreatic cancer patient?
That's a really good question, actually. And this can be sometimes quite difficult, especially if you're coming in as an on-call doctor and you're not sure how much everyone knows or what the agreement has been. So I often find that asking maybe the family to go into a quiet room, so the idea being that you could speak to them, but then just quickly having a word with the patient and asking them what they know about what's going on and how much their family know and what they want their family to know, because the most important thing is making sure that the confidentiality of that patient that's your responsibility is maintained. And it may be that the patient may not have told their family the full details or may not want to, so then you need to know that from the get-go. You don't want to put your feet into a great mess, especially when you've got lots of other priorities on call. But equally, you tend to find that patients' families are really well informed, and also the other people to ask in this instance are the nursing staff, who tend to know much more, being much more up to date with the family situation and what's happened in the normal times when when the normal ward staff have been there. So using your other colleagues to help you in that situation is really helpful.
Okay, lovely. Another wee one is just, what do you carry around during your shift, and to make a list of all the jobs? Could we have a session with this way to make a list?
That's a really, really good question, actually, like stuff equipment to carry. So ideally, hopefully, or well, you might be wearing your own clothes, but in sort of post-COVID times, most people are wearing scrubs, which is really good because they've got loads of pockets. Making sure you've got at least one pen, if not two, having them in different places. So if one drops out, you've still got another pen, because you're not going to get a pen for love nor money in an NHS hospital. Having your phone with you, there's loads of great resources that you can get on different apps. Having the BNF app downloaded, so you can quickly check prescriptions. Lots of hospitals actually have an app called Induction, which has, you can literally Google search on it from your hospital. You can log into your hospital through it, and then you can search for wards or certain registrars, and it will literally tell you the bleep numbers or the extension numbers that you can call. So that's really quick. So you don't have to go through switchboard, you can just directly call them. That's really helpful. So having all those resources and things on your phone. Having a stethoscope. I know that it's surgery, but you really do need a stethoscope because a lot of your care is going to be dealing with medical problems for patients, especially when you're on call in surgery. Then also having, if you can, having a pen torch with you can be quite helpful just when you're assessing someone's pupils. And then I'd say also having a little snack with you, like a cereal bar or something, so that if you are run off your feet to the point where you don't have a chance to have a proper full break, you can at least have a snack. Lots of people like to carry a water bottle around with them as well. And then obviously having your list. So you may well be given a surgical list. So these are sort of A4 sheets of where all the patients are written down with their identity numbers and exactly what's happened. And in some places, these can be super detailed with like the bloods, up-to-date bloods and CT results and things on them. Or in some cases, they can be very brief. So if you're given one of them, then holding on to that. And also with you having a blank sheet of paper, as I said, with all of the patient's details on, sometimes it can be helpful to actually just grab a sticker from the patient's notes and just put that on there, so you've got all of the relevant identity info for them while you write things down. And say that's the core stuff I'd want to have with me on an on-call shift.
Okay, lovely. And just before we ask the next question, just thought I'd mention for the 56 who are left on the webinar, if you fill in the survey, you get a wee certificate just for your attendance. So that's a wee incentive to get that done, okay? Next question, is it good practice to escalate in order, i.e. to your SHO first, or do you think a patient is really sick, should you escalate straight to the reg?
Ooh, what does it mean by an order, sorry?
Like, should you go straight to the F2 or just go
to
a more senior?
Sorry,
you know?
I was thinking whether you meant like a blood test or something like that. No, okay, so this can be a hard one, especially at first, to sort of gauge. But if a patient is critically unwell and is rapidly deteriorating, then I would go to the senior person first, go straight to the reg. If it's a specific thing to do with the operation that the patient's had, then definitely going to the registrar is the best thing, because they're the one that has the power to organise theatre and getting the patient back into surgery if needed. And also they're likely to have the most specific specialty expertise in dealing with that problem as well. But again, if you can't get hold of them, then getting any member of junior staff is the best thing to do. And I wouldn't feel put off to call a registrar if you're confident in what's wrong with the patient or the background of the patient and you feel that you can do a good handover. Then sometimes getting contact them for advice can be the best thing to do, because the SHO may well just have to contact them anyway. So it's a bit of a judgment call there, but in general, I'd always go to the SHO if I can, but if someone's sick, then go straight to the reg. Yeah, that's absolutely fine.
Okay, 2 questions left. When taking a handover, would it be a good idea to write everything down and ask the person giving it to slow down, as some of the handover examples had a lot of information?
Yeah, absolutely. So that's something, sorry, I didn't mention explicitly, but I would go to handover with a piece of paper and take, so as the same as I do when I get bleeps during the on-call shift, taking down the information that the person is telling me. So critically taking down their name, where they are, and their identity number or date of birth. And then I just write, like in shorthand, like a brief summary of what there is. And then I make myself a jobs list of things that the person wanted me to chase. So in the case I gave you, it would be chasing the chest x-ray and also doing a fluid balance assessment. And I'd write a time that I needed to do that, just to jog my memory later on when I go through my list of jobs to check to do that. And yeah, definitely ask someone to slow down. even if it's someone really senior, just say, sorry, could you just repeat that for me? And also clarify the hospital number as well, because that can sometimes, the digits can be missed and then you just can't find the patient if they've got quite a common name.
Okay, lovely. And final question, what apps do you recommend downloading?
Oh, so I covered this a little bit before where I said the BNF app and induction. I'm actually just going to get my phone up and see what other medical apps I have on there now. But there are loads and everyone has individual preferences. So I have the up-to-date app as well, which is quite academic, but really helpful for if there's an unusual condition, you just wanted to have a read up on it, especially if you're on call and it's something you've never encountered before. That can be quite useful if you've got a bit of time. I have the iResus app, which is from the Resus Council, and that has all of the ALS algorithms for cardiac arrest, tachycardia, bradycardia, and the pediatric ones on there as well. So that's really good if you're an extremist and you're just not sure, you can't remember the algorithm, or it's not available on the trolley for whatever reason, then you can get that up. And then from when I was on orthopedics, I've got the OrthoFlow app, which was a couple of pounds, and that's basically got the whole body on it and just all the different fractures and what they might look like on an x-ray and how to manage them. And those are the main ones that I used really. And then our hospital had an emergency medicine app, which has like lots of guidelines on like how to manage hyperkalemia in the hospital guidelines. So if your hospital has something like that, that could be really good. I think that's all of them. That's probably the best ones I'd recommend.
Lovely. Thank you so much. I think that's all of our questions. So that's the end of the lecture, folks. Thank you so much for coming, and those who stay to the end and sort of fill in the wee survey. That'd be great. Thank you so much.